السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. At last.
أخبارك يا دكتور؟ صباح الخير، صباح الخير جميعا.
السلام عليكم. وعليكم السلام ورحمة الله وبركاته. So I was not able to hear you, but alhamdulillah now I can hear you. So I think it's better to start our session. And this session, as you know, is going to be about focused history and an examination of for dysphagia. So first of all, do you hear me well, all, please?
Yes.
Okay.
Yes, doctor, very clear.
Yes. So I would like to make this session as an interactive session. So I'll not be lecturing because I think now you have got a good idea about how to take history and do physical examination. So we are going to apply what you already know about history taking and physical examination for a patient who came to the hospital complaining of difficulty in swallowing or dysphagia, considering the clinical features of dysphagia. So we are going to apply our knowledge regarding dysphagia for a patient who came complaining of such disease in the hospital. Okay. So before I start, I would like just to ask you about when we say focused history and focused examination, what do you mean by that?
Regarding the symptoms.
Sorry?
The symptoms, we try to figure out what is the cause of the symptoms.
Okay, يعني give me just a broad description or broad idea about what do you mean by focus, because you frequently encounter this, particularly in the exam. For example, they ask you to do focused examination of that system, focused examination of that system. So it's better to know first of all, what do you mean by focused history and focused examination? Yes, any other opinion?
Like with the patient complaining of dysphagia, I will ask him about all the questions regarding the dysphagia, the onset, the progression, the associated symptoms.
Okay, yes.
Particularly to the symptoms.
Yes, any other idea?
Yes, doctor.
Yes.
Regarding to the dysphagia, I will not go to assessment any other system other than the GI tract or the pharynx or the esophagus and the pharynx itself. I will not go for abdominal examination.
Okay. Yes, any other idea about what do you mean by focused history or focused examination?
Yes, doctor, we will examine based on the complaint of the patient or based on the organ involved.
Okay.
For example,
yes.
dysphagia, we will examine also the neuromuscular system.
Yes. So yes, I will actually all of your sentences, all of your answers, all of your ideas are relevant. So what do you mean by focused mainly is we are not going to take history like general history. We're going to take history focusing on the disease which is involved. Okay. So it will not be general history taking. It will not be general physical examination. It will be focused considering relevance of the system which is mainly involved. So for example, in this lecture, we are not going to take general history. We're going to take history considering the possibility, differential diagnosis, etiology of dysphagia. Okay. So first of all, this is what do you mean by focused. And another question, please. When we say, for example, examination, focused examination, for example, of a certain system, does that mean we are going to examine only that system, or we may examine also other systems?
First, we will do the localized symptoms, the examination, and then we will do general examination and the relevant examination. Like we can do abdominal examination or chest examination to complete the test.
So you mean you start by general examination and then you examine the system which is involved, okay? And then do you examine other systems? Do you examine other systems also? This is the question. Do you examine also other systems other than the system which is mainly involved?
In general examination.
Yes, of course.
Doctor, I think if it has a role in this case, I will go for it.
If it's relevant, doctor.
Okay. Yes. Yes. What do you mean by relevant?
Relevant to his condition for her condition.
So considering examination, for example, what do you mean by relevance? Why do you examine other systems?
So dysphagia may be related to the GIT or the chest.
Okay.
This.
Yes. Okay.
Or
Okay.
maybe
Any
neurological.
other idea? Yes. Any other idea? Any other comment?
Yes, Doctor, as I said before, for example, for dysphagia, we have a role in the nervous system in controlling the involuntary movement of the muscles. So we need to examine the nervous system as well, especially cranial nerves.
Yes. Again, your comments are and ideas are all relevant, and I think the most important thing that we when we say, for example, examination of the system, it does not mean that we only focus on the system. However, we need also to examine other systems in which we expect to find signs, in relation to the disease. Because some diseases give rise to signs in more than one system. Do you agree with me in that?
Yes.
Yes.
Of course, like in
I
case of
will give you an
hematoma or
example.
cranial
Yes.
tumors.
Yes, I will give you just an example, a very simple example. If you are asked to do a focused examination of a groin hernia, for example, it's very important to examine the abdomen, for example. For evidence of abdominal distension, for evidence, for example, of visible peristalsis, for example, for evidence of exaggerated bowel sounds or increased bowel sounds, for evidence for example, a palpable or hypertrophied prostate, and so on, because we know that groin hernia can cause, for example, intestinal obstruction. Okay, so this is just one example. Another example, as we have previously mentioned, for example, in examination of diabetic foot, we don't only examine the feet of the patient. We also need to examine the epigastric area, for example, and we also examine over the carotid pulsations. Okay, because we expect to find signs there in relation to diabetes. So diabetes does not give rise to signs only in the lower limbs. It gives signs also to in other areas, in other parts of the body. Okay, so if you have time to do this, you should do that as part of your focused examination. Or if there is no time, for example, in the exam setting, you say, to finish my examination, I would like to examine, for example, the abdomen. I would like to examine that part or that part. Okay, is that clear?
Yes.
Nice.
Okay. Yes. So now we want to apply this concept, focus examination and history taking for a patient who came to the hospital complaining of difficulty in swallowing. Okay. So as I mentioned, please, I want to make it as an interactive session. I will not be lecturing. We will be discussing, talking to each other. Okay. And I also prefer to assign certain tasks to certain groups, if you don't mind. I will ask A1, A2, B1, B2 to give me the opinion or to do a certain task regarding focus history and examination of this page. So let us start first by history taking, and then let us move to physical examination. So I would like to be systematic, so going one by one according to the classical format of history taking. First of all, I would like the members of group A1, please, members of group A1, they know themselves, of course, to tell me about the personal information, the importance and relevance of personal information in the part in the history, in the initial part of the history regarding this failure. Yes.
Yes. First of all, we'll ask the patient about his name and age, because when we got the age, we can distinguish between some causes of dysphagia. For example, in young ages, the cancer chance is less, and like that. And the personal history. Yes, doctor.
It's good, Faisal. But does the name make any difference? The patient name is Muhammad or Ali or Abdullah. Does it make any difference regarding dysphagia?
Yes, because I have to check the right patient and to take the right history from the right patient, just like that, to confirm the identity.
But this point particularly we apply for any patient and for any disease, no?
Yes, right. I have
Yes.
to ask about name.
Yes. Okay. So yeah. So the age, yes, I agree with you. The age regarding the age. Yes. So what you have said regarding the age, would you repeat yourself, please?
Yes, regarding to the age, I can distinguish between the acquired conditions and the congenital conditions in case of younger children or in case of older people, because the cancer will be most common in old age, but in young age, the congenital defects will be more common. So that's the
to be practical, please give me examples, because when we take examples, then we will be practical, no?
Yes, for example,
esophageal cancer. Yes, I agree with you. Esophageal cancer tends to happen in elderly patients, 60, 70 or six, 7 decades of life. Yes, for young patients. Any example for young patients?
in young patient, maybe there is certain fistula or certain diverticula, like pharyngeal diverticulum. Maybe it will appear first in young age.
Yes. Yes. Yeah. Yeah. I think generally, yes, I agree with you. That some conditions tend to happen at maybe at young and adults around the age of 40, for example. Like if we consider, for example, Plummer-Vinson syndrome, this is characteristic. It happen around the age of 40 years. While, for example, esophageal cancer and things tend to happen at later age. Yes. So this is regarding the age. I need another member
Also,
from the group. Yes, please.
Doctor, الجندر, for example,
Yes.
Plummer-Vinson syndrome more common in female.
Yes. Yes. Complete, please, regarding the gender. This part of the this task is for group A1, please. I will go through all groups.
Also, after we complete the history, we can ask about the aggravating and relieving factor.
No. Still we are in the gender, in the sex area, Faisal. So
Okay.
who started talking about or the gender or sex? Please complete. The one who started to talk about sex and gender.
Doctor.
Yes.
Also, if you maybe ask about the nationality, maybe
No.
patient.
Please, still in gender, in sex. So you said that Plummer-Vinson syndrome tend to happen in females. Give me an example of a disease which is more common here in males, for example, regarding this stage. Any idea? If we took, for example, esophageal cancer, what do you think? If we took esophageal cancer, is it more common in males or in females?
Males.
Yeah. So
Males, of
yes.
course.
Yes. So there are gender differences in this stage that needs to be considered, and that's why asking about the patient's sex or gender is important. Yes. Now, what's next? What's next?
Residency or nationality.
Yes. Tell me about residency, please. One by one. Tell me about residence.
For example, if there is an endemic areas with Chagas disease, it
Yes.
will increase
Give me
the
example.
percentage of achalasia.
How Chagas disease is related to residence?
To residency.
Yes.
For example, if he lived in the endemic areas with the Chagas disease,
Can you give me an example?
parasitic, it's a
Can you give me an
parasitic
example?
How? Achalasia.
Yes. Where?
course,
For example, where are the areas that has got relation to residence regarding achalasia? Which part of the world, Doctor? Which part of the world?
Doctor, I think tropical area.
Mexico.
America.
America.
Yes. So please give me examples. When you're talking examples, this ensure that you know. Yes. So, for example, if the patient lives in South America, for example, or he lived there for a while, or if he gave history of traveling to an endemic area, so this might be quite relevant to the patient. As you mentioned regarding the possibility of Chagas disease, which give rise to a clinical picture which is typical of a cholera. Okay. Yes. Still, the question is for group A1. What other points in the personal information? Sorry. Any other example of residence? Any other example of residence? What about esophageal cancer? My question here. What about esophageal cancer?
It will be not common in the developed countries as the well-developed countries.
Give me examples. Yeah, Faisal. What do you mean by developed? Give me an example.
Like, for example, in America or in any city in the America, it will be common because this is related to the westernized food, but in other places like in Africa, it will not be as common as America.
Actually, westernized food, Faisal, is not an important. I don't think it's an important risk factor for esophageal cancer, but there are certain types.
I mean, westernized lifestyle.
Yeah. What do you think about Japan? What do you think about Japan?
One of the risk factors is smoked fish or food.
Yes.
Which is more in Japan.
What do you think about Japan, Faisal? First world or second world, and China also?
Yes, as Abdullah said, place with the highest amount of smoked meat or fish, it will be higher.
Yes. So,
it's related.
So in China there is a certain belt. I think in South China, most likely, and also Japan, there are certain areas which quite endemic in esophageal cancer, but not only that, also in Africa. Some areas in Africa also has got some increased incidence in the risk of esophageal cancer, for example. And this will take us to the next point in the personal history. Yes. So what do you think? Still, the questions for A1.
We have to ask about the aggravating and relieving factor.
We'll talk about that when we come to the chief complaint, but still we are in the personal.
Doctor, I think occupation also. Didn't mention it.
How occupation is related?
If there is an area with high amount of smoke and toxicity there, maybe it can cause an esophageal cancer.
Yeah, but we already know the risk factor for esophageal cancer. I don't think esophageal cancer is related to job. Any one of you have came through any information in the textbook or in the literature, research article or anything like that indicating that esophageal cancer has not related to job?
I have another idea regarding different cancer. For example, pharyngeal, with the pharyngeal cancer or the pharyngeal mucosa, when the patient work in a factory of asbestos اللي يسمى الحرير الصخري، يعني ما اعتقد يكون عنده higher risk، ممكن يصير في كانسر ويأثر على on the deglutition or eating food.
Yeah, but even asbestos is more related to other cancers rather than nasopharyngeal cancer. I think there is no strong relation between any occupational disease and dysphagia, but we may look for any update in this concern. But according to the classical teaching and textbooks, there is no strong relation. At least I'm talking about strong relation. And for example, occupation is very strong related to bladder cancer. Okay, but there is no strong relation like that to apply in case of esophageal cancer. Okay. Yes, but still, what other important information in personal history? Because before we leave it. Anything related to? Do you hear me, please?
Yes.
Yes, yes.
Do you think ethnicity has got anything to mention? I mean the ethnicity of the patient, the ethnical background, or the tribe, for example.
I think, Doctor, now the ethnic groups has not be as before. Before we have 3, but now صار في اندماج واختلاط بالأعراق يعني ما هو زي أول.
Yeah, but yeah, and still, maybe your point is true. Yeah, but still, certain areas you cannot say no. There is no. At least, يعني, it's not like before. But still, in certain parts of Africa, in certain population, for example, the Ashkenazi Jewish. Do you know the Ashkenazi Jewish? This is still recognizable ethnical group. So still, yes, but yes, there is some sort of globalization and amalgamation of races, but still there are certain areas, certain populations more prone to certain diseases. Okay, so for example, people in Caucasians, for example, Caucasians in Southeast Asia, some Africans, some types in Africa. They are more prone, for example, to development of esophageal cancer, for example, and this is related to environmental factors. This is related to maybe to environmental factor rather than genetic. Okay. Yes. So I think it's important to have an idea about that. Do you agree?
Yes, Doctor, we agree.
Okay. Yes. So then after that, after the personal information, then we go to the chief complaint and we just document this chief complaint according to the patient own words. History of present illness, history of present, the stages for members of the, how would
صوتك يقطع يا دكتور.
دكتور الصوت يقطع.
طيب I will change to use the laptop. I will check to use the بحصل ضعف في الشبكة شوية هو هذا. Okay. So members of group A2, please tell me how do you analyze this in order to find out what is the most likely underlying members, please.
Sorry, doctor, we couldn't hear you.
Just 1 minute, Ishaq. Just 1 minute, دقيقة بس. السلام عليكم.
السلام واضح الحين دكتور.
الشبكة أيوة الشبكة شوي بيحصل فيها ضعف بعض الأحيان يعني. طيب. I'm talking now to members of group A2. Please tell me how do you analyze dysphagia in order to find out what is the most likely underlying cause.
Most importantly, the site.
Yes, I agree with you. Yes, I agree with you. Who's talking, please? Who's talking?
Abdullah.
Abdullah, I agree with you, Abdullah. First of all, very initially, I would like to determine what is the site of dysphagia. Tell me how do you decide on this? How do you identify this?
I'm gonna tell him to like tell me where is exactly the level of the difficulty.
Yes. Yes, you can ask about the level of difficulty. And usually, what do patients of pharyngeal dysphagia tell you? Basically, what do they tell you?
That the food gets stuck or something.
Yes, and actually, he will. Yes.
Yes, doctor. I think in the pharyngeal dysphagia, the patient will tell you, I have problem in getting the food to leave the mouth.
No,
He cannot
actually, it's,
swallow. This is in the pharyngeal, but in the esophageal,
yes.
he will say the food is stuck in my chest.
Yeah.
Do not go to the stomach.
Okay, so I will get back to Abdullah here, please. Some patients are not quite sure about whether they have dysphagia or not. He will tell you that I have some difficulty, but he is not sure actually. So if there is any habits that the patient used to do recently, which will tell you that he has dysphagia. Did you get my question, Abdullah?
No, actually.
Some patients, they are not quite sure whether they have dysphagia or not, but there are certain habits that the patient, for example, started to do while he's eating, which indicate actually that he is likely to have dysphagia. You get my question?
No, actually.
Okay. Anybody can understood my question or can ask the question?
Again, please, doctor.
Yeah, I want to
If the
answer.
patient is not quite sure about whether he has dysphagia or not, if there is any habits, new habits that he started to do while he's eating, which might tell you that he's likely to have dysphagia, any habits during eating?
Maybe pain or odontophagia.
Okay. Anybody can explain or can?
Doctor, maybe the patient will say to you, now I have to drink water with food to brush it down.
Yes, I agree with you. And else, and anything else?
Maybe he takes small bites.
Ballas.
Yes, and some patients tend to do the Valsalva maneuver. Do you know the Valsalva maneuver?
Yes.
Yes, Valsalva maneuver is yes. So they tend to do it in order to promote swallowing, because Valsalva maneuver increases the pressure within the esophagus. Okay. So if the patient, for example, tell you about this habits that I started to water frequently while I'm eating, or he's doing some sort of Valsalva maneuver to push the food downwards. So this will signify that he is likely to have dysphagia. This is in case the patient is not quite sure about whether he has dysphagia or not. You can ask him about any recent change in his habits during eating. Is that clear?
Yes, very clear. Thank you.
Yes.
Yes. So this is regarding the site of dysphagia. Yes. What else? Still the question is for group A2. What else, please?
Did it start suddenly or gradually?
Okay. Give me examples, please.
For example, in an esophageal cancer, it will progress very fast. But for example, in pharyngeal pouch, it will progress very slow.
Okay. Any other
Yes. We can.
لحظة يا فيصل, I would prefer members of A2, please. Members of A2 other than Abdullah. Anything can be mentioned here regarding the nature of dysphagia. First of all, we talked about the site of dysphagia. Now we're talking about the nature of dysphagia. Which nature, and give me examples, please. في another member from group A2 other than Abdullah? Raise your hand, please.
Doctor, I'm from A1.
طيب أنا عايز A2. فين A2؟ فين A2؟
يا شباب
معنا
A2
33
شباب A2 عبد الرحمن دوسري، عبد العزيز الشمراني،
معنا 33 participants يا شباب. Where are you؟
رشيد الهادزي، عبد الله عياف، معاذ كريم. وينكم؟
Looks like some students are Some students are just logging in, but they're not interacting. So yes, maybe يا طلال, tell me يا طلال, if you are here, tell me about regarding the nature of dysphagia, which questions you would ask the patient, and give me examples, please. I need you to talk to me, يا طلال. I need you to talk to me, please. Yes, any member in the any student in the class, tell me about nature of dysphagia, please, and how what do you want to know regarding it?
Choose, Doctor. We are raising our hands.
Okay, so who wants to answer? I will lower hands.
I can answer it.
Safe want to answer.
Yes, okay, Safe. Tell me, Safe.
I will ask him about which type of food is first you had difficult to swallow. Is it solid or liquid or both?
Okay, so before this, any other information which might be relevant or important here?
Yes, the severity, doctor. Is it rapid or slowly progressive?
Yes.
Is it associated with pain? Just pain?
Okay.
إذا associated with weight loss, doctor, you will expect esophageal cancer.
We'll talk about this under the underlying cause. We will talk about the most likely underlying cause, but before that, now we are analyzing dysphagia itself. Some diseases are characterized by dysphagia that tends to be intermittent, while other diseases, the dysphagia is progressive rather than intermittent. Do you agree with me?
Yes.
Yes.
Can you give me examples?
Like case of esophageal cancer, it's progressive, and achalasia is progressive, completely collapse. And in case of stricture, it will be a partial intermittent.
Maybe even in stricture, it might also be progressive or constant at least. But for example,
pharyngeal diverticulum, it will not be progressive as esophageal cancer or other diseases.
Yes, here you are talking about the onset, maybe the onset, yes. But for example, in achalasia, due to for example to WEPS, esophageal webbing, like for example Plummer-Vinson syndrome, or in the case of WEPS in the lower esophagus, or in the case of Chattisky ring, if you read about it, Chattisky ring. Again, this is an example of a web in the lower esophagus. These conditions are actually characterized by intermittent rather than progressive dysphagia. What does that mean? The patient sometimes might complain of he complains of periods of dysphagia and then periods of improvement, and like that intermittently. While, as you mentioned, in case of esophageal cancer, achalasia, here the dysphagia tends to be progressive in nature, increasing in severity. Yes. And you have already mentioned.
عندي سؤال بس تكرمت يعني بالبلامر ديسيز او بلامر سيندروم راح يقول المريض احيانا عنده ديسفيجيا واحيانا لا.
Yes, intermittent dysphagia. Sometimes they complain of periods of severity and other periods in which the disease is more mild. Okay.
Okay, thank you.
Yes. So regarding the solid food and liquid food, anyone wants to explain more how it help you to reach?
Can I talk, doctor?
Yes, please.
Bismillah. Solid and the fluid determine what is first will tell me what is the cause of dysphagia. For example, in the achalasia, it is start first for the fluid because the fluid cannot push the wall of the esophagus, so the prosthetic movement will be trapped. In the case of esophageal cancer, it will start first for the solid because it is obstruction. not completely, but there is some space the fluid can go past.
Okay, and eventually what happens? This is just at the start.
Eventually for both.
Yes, eventually it can be for both. But,
Yes, but
will be interested
first,
yes, at the start, yes. Which one is started?
Yes.
Thank you so much. What is your name?
Talal.
Talal. Thank you, Talal. Thank you, Talal.
Welcome, doctor.
Now we did analyze dysphagia itself regarding the site, regarding if any habits signifying dysphagia, regarding the nature of dysphagia, regarding the onset of dysphagia, including to which type of food dysphagia has started. Now, this is the first objective actually of your in the history of present. The second objective, what do you think about the second objective? Now we knew that the patient have got dysphagia. What do you think now we should move to? No.
Examination of physical illness.
Underlying cause.
Cause. Now we would like to find what is the most likely underlying cause. Still, there are questions which might tell you what is the most likely underlying. One of these has already been done, like which type of dysphagia, which type of food dysphagia started. But still, there are some questions here regarding underlying cause. So now think of the clinical features characterizing each type, each disease that give rise to dysphagia, and try to survey this or try to cover this. So I think the stage now will move for members of group B1, please. Members of group B1. Which questions you think needs to be asked, and give me examples, please.
يعني أعطيك دكتور example على disease بعدين نتكلم عن
But objective is to find out. An objective is to find out what is most likely underlying cause. So we'll be covering what or surveying what the clinical features of each disease generally. Okay.
Okay. First, I will go by the pharyngeal pouch or Zinger's diverticulum.
Okay.
The symptoms will be regurgitation of undigested food,
yes.
rumination,
yes.
And halitosis and nicklum within posterior triangle. Halitosis is a bad smell odor due to fermentation of food and digested food. Rumination, when the patient can taste the food after a long time since the last meal. That's all it is. This is regarding the pharyngeal pouch.
Okay. Any other point in the history which might signify a pharyngeal pouch? Think of the underlying cause of pharyngeal pouch. Yeah. What's your name, please?
Safe.
Safe. Think of underlying causes of a pharyngeal pouch. Any question might help you. What is the underlying cause, Safe, of pharyngeal pouch? What is the underlying cause?
Weakening at the Killian dehiscence area between the constrictor muscles.
Yeah, but basically why? Basically why food goes into this area? Basically why?
Increase the pressure.
Okay.
Pressure at the wall.
What about the swallowing?
Also the swallowing. It may be congenital, it may be acquired.
Is in swallowing basically, no?
Yes.
So why swallowing, or in which conditions the swallowing reflex or swallowing can be disordered or abnormal? Any diseases which might affect that?
I have no idea.
Okay, any other member in the class would like to comment here or to add anything?
Yes, doctor.
Yes, please.
Actually, it's because of the neurological and muscular diseases.
Yes.
Because of the pharyngeal pouch.
Yes, give me examples, please.
For example, Zinker's diverticulum. It's a muscular problem.
Now we are neurological and muscular diseases.
Doctor, maybe in case of my enteric nerve plexus, when it's get damaged, the orbach itself, or the nerve supply, the muscle will fail to relax.
Orbach. First of all, Orbach in the esophagus. We're now talking about pharyngeal pouch.
For achalasia, Orbach. In case of multiple sclerosis or pulpal palsy.
Yes, multiple sclerosis, pulpal palsy, Parkinsonism.
Myasthenia gravis.
Yes. Yes, all these diseases can give rise, can predispose the patient for development of a pouch. So if the patient is a known case of Parkinsonism, for example, or known case of any neurological or muscular disease, muscular dystrophy, for example, myasthenia gravis, for example, okay, all these diseases can predispose the patient for development of pharyngeal pouch. So don't forget to ask about this. Yes, so good. This is good. I need another student to comment on another disease, please.
B1 جروب يا شباب.
جروب or any group دكتور.
So B1, please.
لا.
Maybe she has post-cricoid cancer.
Yes. Tell me about post-cricoid cancer. Which questions you would like to ask here? Doctor, any feature which might signify post-cricoid cancer? It is like pharyngeal pouch, and that is pharyngeal. But anything specific to post-cricoid cancer?
Hoarseness of voice.
Ear pain and voice, hoarseness of the voice.
Yes.
The pain
Yes. Yes. Onset. First of all, we have already talked about onset. What do you think about the onset and progression?
Very acute. Very acute.
It will be quick or fast in relation to other benign causes. And features of metastasis. Features of metastasis or local or local of nearby structures, like, for example, hoarseness of voice or bleeding, for example, bleeding through the but mainly hoarseness of voice or difficulty in respiration, for example, or something like that. It might signify the possibility of cancer at the level of the pharynx or the cricoid cartilage. Yes. Any other what related to cancer in general? They mentioned here.
Cachexia. Cachexia.
Loss of weight, yes, loss of weight. And what else?
Weight loss.
Constitutional symptoms, doctor.
Yes.
Metastasis.
We can palpate lymph nodes.
No, at the level of the history, please. History, please.
Like, for example, fever, loss of weight.
Symptom of metastasis.
Yes, and don't forget family history. Usually, in cancer in general, this is not only for esophageal cancer, for any cancer, not only in dysphagia. Don't forget to ask about a positive family history, and if the patient has got a positive family history, where will you mention this?
The family history.
No, I will not leave such important information to the end of the history. I will mention it where? As part of the history of present illness. Why do you think it has to be mentioned here?
It's maybe the cause.
Because it is relevant. Because it is relevant to the differential diagnosis. Any information which is relevant to the differential diagnosis or the most likely disease has to be mentioned where? In the history of present. Even if this information is basically part, for example, of a drug history, or social history, or family history, or past medical history. Take it from there and mention it where? In the history of present, if it is relevant. The family history here is relevant. So I will not leave it to the family history. I will mention it where? As part of the history of present, because it will be important for the audience to hear such information. Clear?
Yes.
Clear.
Yes. Yes. What other questions which will tell you about the underlying cause? Members of group A1, B1.
Doctor, maybe she has esophageal webs, Plummer-Vinson syndrome.
So which questions you will ask here, which we might signify Plummer-Vinson?
Maybe her skin will, the iron deficiency signs, maybe her skin will be pale. She has, she's weak in general.
Pallor is by examination, doctor, not by history. So which questions you will ask him regarding anemia? Which question, doctor, which might signify anemia?
Easy fatigability.
Yes. What else?
Dyspnea.
Palpitations. Only by examination, Faisal, we are talking about history. So irritability, palpitations, syncopal attacks. Yes, all of these features signify what signify signify Plummer-Vinson syndrome. Yes. What else? One student talked about GERD. Tell me about GERD, please. One student commented about GERD.
correct. esophagus.
مين ذكر الجير لو سمحتوا؟ في طالب commented on جير. خلينا نشوف الكومنتس. طيب معاذ الغويني. Can you hear me, معاذ؟ can you hear me, معاذ? Anyone can tell me about how GERD is related to dysphagia? How GERD is related to dysphagia?
Yes, doctor.
I'll answer in 2 ways, يا شباب. I'll answer in 2 ways. Only 2 ways.
By only what?
Esophageal strictures.
I'll answer in 2 ways.
Can I say, doctor?
Yes, please.
We have two ways to get dysphagia by GERD. The
Yes.
first one, doctor, it's about peptic structures.
About what?
And by structure.
Yes, which type of structure, yeah, doctor? Which type of structure? What do you call it?
Peptic structure.
A peptic structure. Very good. This is the answer that I wanted to hear. Peptic structure, yes.
And
Yes.
and the another way, but indirectly, doctor.
Yes.
GERD, gastroesophageal reflux, will develop 7% will develop Barrett disease, Barrett esophagus.
Esophagitis.
Yes.
And it will lead to esophageal cancer.
Yes.
So this way you will get dysphagia, but this is way it's indirect.
Yes. So actually, I'm very glad to hear this rich information from you, all of you participating, mentioning sometimes percentage. And it means one thing that I think now you have a good knowledge about the content of the course. So please carry on. Okay. Yes. So let us now move to other. Yes, but here before we leave GERD, any symptoms which might signify GERD? The students who was talking.
Heartburn, doctor. I'm Abdurrahman, doctor.
Yes.
Heartburn, angina-like pain, indigestion, and this is symptoms of GERD.
Yes. So symptoms like heartburn, symptoms like indigestion, symptoms of retching, all of these might signify or regurgitation of acid sometimes in the mouth and in the pharynx. All of this might signify peptic structure. Yes. So now we move to another disease and other questions.
Another disease example.
Yes.
Like in case of corrosive structure. When the like for example a kid who swallow a battery or chemical substance that may irritate the mucosal lining.
Yes. So history of ingestion of corrosive, but as you said, this is not common. This is only common in pediatrics group of patients, in children. Yes, good. What else?
Esophagitis, doctor.
Yes, esophagitis. Yes. Tell me please about this. Explain please.
Inflammation with the esophagus cause dysphagia.
Yes. Which type of inflammation? Can you mention certain diagnoses, certain diseases?
Certain infections and candidiasis maybe.
Yes, candidiasis. Yes, and
Or herpes zoster simplex virus.
Which questions you would like to ask here, which might signify the possibility of this esophagitis? Very good.
Features maybe or history.
the
Yes,
patient.
history.
Maybe if it's immunocompromised
Yes, very good. So
or has history of HIV.
yes, yeah. Immunocompromised include HIV and
Yes.
yes. So HIV and what?
Chronic diseases
Chronic diseases. Yes. What else?
or morbidity.
Yeah. Yes. What else? Patients who are taking immunosuppressant drugs.
Immunocompromised cortisols.
Yes. Diabetic patients. Diabetic patients. All of those patients are
All as risk factors.
and bronze. What is your name, please?
Nasser.
Nasir. Good, yeah, Nasir. Good.
Thank you.
Yes. What else? Another disease that needs to be surveyed?
Doctor, we can also ask about GERD and esophagitis if he has heartburn.
Yes. Yes. It is esophagitis, yes, but it usually gives rise to peptic stricture. This is how does it produce? This is how does it give rise to dysphagia, or through cancer in the lower third of the esophagus. Yes.
Okay, clear.
What about achalasia? What if the patient is having achalasia? Any features which might tell you that this is most likely achalasia?
Yes, doctor.
Nocturnal cough.
Nocturnal.
Yes.
Nocturnal cough and hoarseness of the voice.
Yes.
And the patient had a travel history. He traveled.
Yes.
and he came back.
Yes. 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 So
Regulation, doctor.
sorry. Yes. Travel history. Yes. So like that. So yes, as you mentioned, nocturnal coughing or choking. Sometimes the patient might awake coughing or choking because of aspiration. Yes. And in addition to that, sore throat and also repeated chest infection. Repeated chest.
Doctor, I have a question for you.
Yes.
كيف دكتور المريض في عند الكليزيا يصير عنده acidic regurgitation؟
مو necessarily acidic، ما بتكون acidic actually، لكن الايديا in the aspiration. The idea in the aspiration itself. The aspiration will cause choking and will cause nocturnal coughing and will cause repeated attacks of chest infection, and eventually those patients they can develop lung abscesses and all these respiratory complications in relation to regurgitation.
واضح.
Another okay, so this is regarding achalasia. Okay, so I think these are the most important questions that you would like to cover to identify the underlying cause. And by this, we finished the history of present illness. Okay, by this we finish the history of present illness, because in the history of present illness we mentioned all the important information relevant to the disease. Sorry, yes, just one point, yes, please.
Can we decide a diagnosis or something by which what does the patient feel easier to, like for solids?
وضح صوتك شوي لو سمحت، وضح صوتك شوي.
I said wait. I said if you ask the patient like if you find what is easier to swallow, for example, solids and liquids.
Yes.
So is it important, the history or not?
Yes, it's very important, as we have already mentioned, that if dysphagia started for liquid, this might signify achalasia. If it started for solid, this might signify esophageal cancer. So this will tell you between these two conditions, because these are the most important two causes of dysphagia: esophageal cancer and achalasia. Okay, and this question will help you to differentiate. Is that clear?
Yes.
So what do you think we missed or we did not mention yet regarding the underlying cause?
Doctor, in the structure we have two causes. Another causes. We have corrosive material and pills.
Yes, we have mentioned
structure.
Yes, we have already mentioned the corrosive. And pills is not very common actually. It's very rare. But you have already mentioned the corrosive structure. But it's good to know that pills can cause also strictures. What about the risk factors of esophageal cancer? Anything needs to be mentioned?
Yes, doctor.
Yes.
Smoking, alcohol consumption, Barrett's esophagus, as we discuss, and genetic factor, the family history is very important. The onset, doctor, I think it will be gradual, associated with weight loss and
Yeah, but
feature of resistance.
Yeah, but the question here is regarding the risk factors. So you mentioned smoking, and you mentioned alcohol consumption, and the type of food, particularly smoked food.
Yes.
Yes, these are risk factors needs to be mentioned here. This is another example. When do you move important information from other parts of the history, and you mentioned it where in the history of present illness, because smoking and alcohol usually are part of social history.
Socialist, yes.
We don't wait here. We don't wait till the social history here because they are quite relevant. So we take them from there. We mention it where in the history of present illness, but don't repeat them again. When you mention them here, don't repeat them again in the social history. Okay.
Okay.
Yes, so by this we finished the history of present illness, and then you complete the rest of the history as usual. We complete the rest of the history as usual. All the important information regarding this page has now been covered. Yes, Faisal, do you want to say anything?
Doctor, I just want to ask about two things. I have forget the idea, the information regarding to the Japan and South China. The smoked food is the most common cause, and regarding to the South America, so we can say Chagas disease.
Yes. Yes, this is correct.
Okay, thank you.
Okay. So now we will move to the physical examination. And what do you expect to find on physically? Again, we go one by one, please, systematically, until we finish. So now the stage is for group B2. The stage is for group B2 to tell me how do you conduct physical examination of a patient with dysphagia. Yes, please.
Inspection, doctor. We will start with the inspection.
Any other member, Ya Abdurrahman, please. Any other member from the group? Any other member from B2?
يا شباب أحد في جروب B2. شباب.
فين هم الشباب هذول اللي تنادي عليهم يا عبد الرحمن؟ هم they are with us.
موجودين.
But maybe they are not with us. Maybe they are.
أنا موجود دكتور.
موجودين.
Yes, tell me please. Anyone of you tell me please, how do you start your physical examination?
Starting by inspection, doctor.
Inspection of what?
Of the area that need to be examined, يعني مثلا from outside.
Let's do general inspection.
Or general examination, I would say general examination.
Yes.
You have already mentioned, Ya Shabab, general examination is part of any examination. You start any examination by general examination first, and then you move to the involved system, unless you are instructed to skip general examination. At that time, you skip it. Okay, but otherwise, you start usually by the general examination. This happens only in the exam, because in the exam, there is no time. Okay, so tell me again, please, the student who was talking. Who was talking? Who was talking?
شباب موجودين.
What's your name, please?
عبد الكريم العتيبي.
Allah ya Abdul Karim. General examination. Tell me what do you expect to find?
General examination.
Yes, please.
شوف الفيتال ساينز والسكين if there is يعني مثلا اللي تشوف check previous scars.
عندنا فورمات يا عبد الكريم للجنرال اكزامينيشن، يعني from where do we start and where do we end. So I would like you to go like that, please. What do you think we should start? How do you think you think we should start? First of all, what about the general condition of the patient, Ya Abdul Karim? what about the general condition of the patient يا عبد الكريم؟
كيف دكتور؟ I didn't get it والله.
General condition of the patient, how the patient look? How does the patient look? Could this be relevant in this phase?
General appearance.
Could it be relevant?
Looks
Could it be relevant to dysphagia or any cancer, any malignancy?
wait. Doctor,
Yes.
it looks ill, pale, and lose of weight. He lost
Yes.
weight.
So all whether the patient look, for example, emaciated. What do you mean by emaciated?
The thin condition, or the thin, or the
Emaciated is significant weight. The patient looks underweight for his age, for example, generally by general inspection because of significant loss of weight. And after that, examination of the eyes, as you mentioned, for what?
Maybe discoloration.
Checking for jaundice, anemia.
Jaundice and pallor. Jaundice and pallor. How could this be relevant to dysphagia?
metastasis, doctor.
Yeah, in case of cancer,
Post-coracoid cancer.
metastasis, yes, you can get jaundice, metastasis to the liver, and pallor. In any chronic disease or malignancy, the patient is expected to be pale. Yes. So yes. So and then
Doctor,
what do you?
I have questions. Can I ask them?
Yes, please.
Regarding association symptoms with esophageal cancer, you said association feature of metastasis it will be jaundice and hemoptysis, and this is logic. But what about pneumothorax? How can he develop a pneumothorax?
Yes, pneumothorax is due to local infiltration of the parietal pleura and the bronchi. Okay, so you get invasion of the pleura, and then you get pneumothorax. So this is due to local
esophageal cancer.
Sorry.
In esophageal cancer.
Yes, in esophageal cancer. Esophageal cancer, one of the complications is due to local infiltration is development of pleural effusion when the pleura is breached by the malignant cells.
Okay, thank you so much.
Okay, where do you go after you finish examining the head? Where do you go?
Hand.
Hands.
Neck.
The hands. What do you look for in the hands? What do you look for?
Look for the palm and dorsum of the hand and the nails, and then check the pulse rate and comment the pulse rate.
What do you look for exactly? Can you tell me what do you look for?
We look for pulmonary edema or swelling of the fingernails.
But pulmonary edema, is it related to dysphagia? Is pulmonary edema related to dysphagia?
Maybe damage to the liver by the esophageal cancer.
Yeah, but this you only got metastasis in the liver, but the liver function in general can be normal. Usually, you get this pulmonary edema if you have got a chronic liver disease. So, what else you might look for in the hand? Clapping is related.
Sorry, clot?
Finger clapping, is it related?
I have no idea.
It might be, yes. We know that clapping is not a major feature, a major sign in case of esophageal cancer. It's more relevant to cardiac disease, more relevant to lung disease, more relevant to liver disease, but still, as for dysphagia as a part of esophageal cancer, as part of GI cancers, you can get clapping. Yes. What else in the nails you look for?
We have spawning of the nails.
Yes, which is known as
Colonychia.
Which indicates, yes, what?
Iron deficiency.
So it will be related to which disease?
To many diseases, iron deficiency, anemia.
Which disease regarding dysphagia?
Plummer-Vinson or Constant Bailey syndrome, I think. The other name.
لا الاسم الثاني يا What's your name دكتور؟
وش الدكتور وش تقول؟
اسمك
أنا سيف الكثيري.
سيف الكثيري. The other name يا سيف is Patterson Kell. Patterson Kell. Okay.
Okay.
Yes. So after that you said the pulse. Why is it important to examine the pulse in patient with dysphagia?
Very important to check the vital signs. Part of general examination to know if the patient is lethargic or anxious regarding the pain if he has pain.
How can you link between dysphagia and pulse volume, for example?
It will be increased, of course, due to tension, the stress.
Yes. Any other opinion? How can you link between dysphagia and pulse?
Basically, the patient trying to get over this pain, and it's a normal sympathetic pathway.
Yeah, remember the patient is not ingesting normally. The patient is not ingesting normally
constant pressure
for fluids. So the patient might be dehydrated, no? When the patient comes to the hospital to you, he might be dehydrated because of poor oral intake, particularly fluids. So he might be, for example, hypotensive. He might have a rapid pulse. He might be having a small volume pulse and so on. Okay. This is basically related to inability to swallow or to ingest fluids normally. Okay.
Yes.
So now regarding the esophagus, do you expect to find many signs or things like that in esophageal examination or in dysphagia?
Where in the hand?
No, regarding the esophagus itself.
Maybe the neck, the lymph node. We will be the lymph node.
Yeah, for the esophagus, we don't expect to find any signs or things like that. So why do you think this is true?
Because it has nothing to do with the hand.
Because
except pleural Vincent.
Yes. Any other idea or comment from the rest of the class, please? Why do you think we usually don't expect to find many findings in the esophagus? Okay, I will explain it myself. Because the esophagus is deeply seated in the chest, so you cannot feel the esophagus like what we can maybe in other systems. So we don't expect to find many signs regarding the esophagus itself. Okay. So where else you go?
We go up
neck
little bit. We check the pressure by sphygmomanometer, and after that we go to the neck and palpate all the neck and the lymph nodes.
Which lymph nodes you will be interested to look for?
Virchow lymph node.
Virchow.
And all the neck, we palpate all the neck mainly.
What is Virchow lymph node?
It's lymph node, the neck.
Toroser sign. It's in the neck, doctor.
Supraclavicular lymph node.
Right or left? Right or left? Left. Yes, it's left. Enlarged left supraclavicular lymph nodes. The lymph node is known as Virchow. And it's not actually. Is it characteristic of esophageal cancer?
Any GIT cancer.
Abdominal cancer.
Yes, even in testicular cancer, you can get these lymph nodes enlarged. So it's not quite specific, but it is indicative of or supportive of the diagnosis. But what do you call the sign? As you mentioned, you call it Trozier sign.
Trozier sign.
Yes. Okay. Yes. What else after that? Where do you go?
Normally, we go to the lower limb.
Before the lower limbs.
Eyes.
You want to examine the chest? The eye is already finished as part of general examination. Do you want to examine the chest? Any findings expected in the chest?
So it's deeply seated. I think there's no signs. Maybe.
The tumor usually invades where locally? Invades in the chest. So it can invade in the hilum, in the hilar lymph nodes, in the mediastinum, and it can also involve the parietal pleura, as I have mentioned. So one of the findings is pneumothorax. You can find pneumothorax. Okay, sometimes you can find some cavitation or consolidation. So examination of the chest could be relevant to dysphagia. Is that clear?
Clear, doctor.
Clear, thank you.
Where else you go? Where else you go?
Abdomen.
Abdomen as a part of
Yes,
the examination.
Tell me, what do you look for in the abdomen?
Liver organomegaly.
Yes. Hepatomegaly. Hepatomegaly. You mean hepatomegaly?
Yes.
Maybe edema.
So palpation of the liver, lower edge, for example, liver span could be related. Yes. What else?
Are you talking about Dr. General examination because we are lost? General examination or about dysphagia?
We are talking about focused examination of dysphagia. Now we are looking for metastasis.
Features of metastasis in the abdomen.
Yes, exactly.
Examination, yes. So what else?
Ascites.
Ascites, yes. So which test you do for ascites? Which test you do?
Wave test.
Shifting belly, doctor.
What are the two tests that we usually do for ascites? This is one. What are the other?
Flank.
We do the wave. We نسقع بالإصبع.
Other test. We do it in case of massive. In case of massive ascites, the shifting donus is not suitable. Do you agree with me?
Yes.
Yes.
So which test you do in that case if the patient has got a massive ascites?
Fluid thrill,
Wave,
doctor.
Yes.
Fluid wave thrill.
Yes, good. Fluid thrill.
Fluid wave.
Yes. Or no, we call it fluid thrill. The test name is fluid thrill. What do you feel? You feel for a wave. You feel, yes, for a fluid wave, but the name is fluid thrill. Okay, that clear?
Clear.
Okay, where else you also go?
Lower limb.
Lower limbs, yes. Tell me, what do you test for in the lower limbs?
Edema.
Lower limb edema. How do you test for lower limb edema? Can you please?
By one law, by using the thumb above the median malleolus 1 inch for 1 minute.
Yes, a rule of one. Yes, very good. Rule of one. Are you all aware about rule of one in testing for lower limb edema?
No, can you explain it, doctor?
One finger, 1 inch above the medial malleolus, testing for 1 minute. Okay? 1 inch, one finger, 1 minute. Okay? What else you test for in the lower limbs, please, considering the metastasis?
اعتقد دكتور ما عندنا باللور لمب الا اللور لمبديما والكابيلاري ريفل.
The capillary refill, is it related? Capillary refill, is it related?
I think it's not related.
Not related, yes. So what other important thing you might need to test for the lower limbs regarding the metastasis?
Reflexes.
No, reflexes are not related to metastasis.
Joints. Okay.
Neurological assessment.
Think of metastasis of esophagus. Where does esophagus metastasize to?
To the liver.
Liver and lung.
And
Pain and bone.
Bone. So if the patient is complaining of any pain in his lower limb, then you have to examine that area. Looking for what? For example, if the patient is complaining of pain in the upper thigh or middle thigh, you have to examine that area. Looking for what?
muscle wasting.
What does metastasis give rise for? No, muscle wasting is not related to metastasis actually.
Cachexia did.
Think of malignant deposits in bone. What can it cause other than pain?
Increase the density of the bone.
You can you can get actually tenderness. You can get tenderness. You can feel a bone swelling. You can feel a bone swelling secondary to the metastasis. Or the patient can have what? Complications of bone metastasis.
Like what, doctor?
Pathological fracture. Pathological fracture. Okay? So you palpate any area of bone pain from which the patient is complaining for tenderness, for evidence of swelling, and for evidence of pathological fracture. So this information is regarding the metastasis of esophageal cancer, for example, to bones. Okay.
Okay.
So I think this is the focused history taking and physical examination in case of dysphagia. I know that we have gone through many information in the history and the physical examination, but I think if you read well about it and you practice these skills, I think it will not be difficult for you, particularly if you have got a structure. Try to put. I think the most important thing for any history or examination, you need to put the structure in your mind. So if you are going to take history of dysphagia, what is the structure that you should follow? Based on information, how could it be relevant? First of all, analyze dysphagia. Second of all, what is the most underlying cause? Then if you gone through that, if you had a structure in your mind, I think it will be easy for you to be comprehensive as much as possible in that case. Okay. So I would like to thank you because I think your interaction was good. I think now you have got good knowledge about the disease. Still, if you need to do anything, you just need to follow a certain structure in your mind and practice the skill. Okay.
Doctor.
Thank you so much, Doctor.
Please, for comments here. The floor is open for questions and comments, please.
ممكن بس تعطينا تلخيص بسيط يعني بالبدايه باخذ الهيستوري بعدين بروح للاكزامينيشن راح ابدا جنرال for the eye for the hand then I will move to the neck to examine the whole neck and palpation then I will go for the abdomen and finally the lower limb. Is that right?
The chest and then the abdomen and then the lower limbs.
Okay.
Regarding the history, personal information, think of the relevance, chief complaint, and then analyze the dysphagia itself as we have done, and then try to look for the underlying cause, and then after that, complete your history as usual. The information that we have not addressed or mentioned in the history of it, just complete it. Like for example, blood transfusion, surgical operations, for example, allergy to food, allergy to medications, chronic medications, you complete as usual. Okay.
Doctor, the chest, what do we do?
This examination. Either you do it or you said I would like to examine the chest.
Okay.
Okay.
Any other comments, please, or any other comments or any other questions, please?
عندي سؤال يا شباب.
I think for other even for other systems, if you talk about focused examination of any other system, for example, this is you apply this concept. I think now it's clear for you. What is the concept of focused examination and the concept of focused history taking?
Yes. Doctor, firstly, I would like to thank you so much, Doctor. Secondly, Doctor, I was trying to call you yesterday because we have an exam, OSCE exam, and this is our first OSCE exam in this year. We don't know how to do it and what it will come. For example, basic science, the OSCE exam, it was only 5 marks and 1 station. In this OSCE, especially we have 2 physical and history taking. One, we have 6 history and physical examination, and we have something called the simulation. like catheter, chest tube insertion. Is this will be for us? And can you explain the test for us, please?
Yes, هم first of all طبعا في البيزك هيكون عندهم اوسبي وليس اوسكي.
احنا عندنا اوسكي، كان عندنا اوسكي 5 درجات في البيسك.
Okay, because the OSCE is objective structure clinical examination. I think in the basic it is a practical exam rather than clinical exam. But anyway, what do you expect? You expect stations of history taking, stations of physical examination, in which you will be seeing either a patient or standardized patient, normal person. Yani, we ask you to do examination of a certain system in that patient. We will ask you to take history from him regarding his disease. We'll give you scenario, and we'll ask you for a certain task. And yes, we can also include instruments. We ask you about these instruments, about their indications, about their complications, and yes, X-ray can come, for example. All these things, yes.
X-ray can come, doctor.
Yes, and even it can.
What? How many stations? How many stations?
Stations will be between 10 and 11. Sorry, between 9 and 11.
It will be like
9 and 11. 9 and 11. Sorry.
بصير نفس السنة الماضية دكتور 21 ستيشنز 11 منهم بريك ستيشنز.
بيكون حوالي 9 ل 11. بيكون ال 9 هذه جزء منها اكتف وجزء منها ان اكتف. يعني اكتف قصدنا بها ايش؟ بيكون فيها interaction either physical examination or history taking. الان اكتف بيكون ممكن يكون فيها instrument وبيكون في rest stations.
حلو، يعني 21 ستيشنز 10 اساسيين او 9 اساسيين. من التسعه نفسها بيكون في ان اكتف واكتف، صحيح؟
انا اعطيتك ايوه اعطيتك رينج، لكن يعني ما حددت رقم. اوكي،
اذا كانت 10 ستيشنز معناها كل ستيشن عليه درجتين. يس.
الدكتور بالنسبه للفيزيكال اكزامينيشن احنا ما سوينا فيزيكال اكزامينيشن على اي بيشنت، بس اللي سويناه بالجامعه.
يس، يعني حتى لو عملته على مانيكان يا فيصل ولقيت قدامك مثلا living standardized patient, you just apply what you know. And I think you know how to do physical exam, just apply it on the سواء كان مانيكان او standardized patient.
Doctor, I have a question.
Yes.
Regarding the instrument, the procedure like catheterization or nasogastric tube.
Yes.
We would perform this procedure, or you just ask us about
you asked two questions around the procedure.
The indication, contraindication, and
yes.
advantages.
يعني ما راح نطبقها.
هقول لك ستيتش ولا انسيرت ان جي تيوب. يس.
عفوا ما سمعت.
هقول لك تو انسيرت ان جي تيوب فور اكزامبل، ولا اقول لك مثلا ستيتش ووند، ولا اقول لك مثلا انسيرت. ask you questions around the procedure.
حلو.
جميل.
طيب دكتور، بالنسبه للجدول احنا في عندنا بعضها مكتوب عليها CSSC وبعضها سيميوليشن سنتر. هل البنفسجيه السيميوليشن سنتر هذه اللي بتجي بالباسف واللي مكتوب عليها CSSC البرتقالي بيجي اكتف، ولا كيف يعني؟ بس عشان نعرف.
لا هذا for the sake of the time table بس يا فيصل. اما انا زي ما قلت لك، يعني اقول لك take history او do physical examination او ask you questions around
على ريل بيشنتس يا دكتور، ولا عاد واحد متطوع يعني؟ صحيح.
والله ممكن يكون ريال، ممكن يكون مانيكان. prepare yourself for any possibility.
السنه الماضيه جاء ريل. طيب اوكي
الله يسلمنا مع الكورونا هذه.
يعني دكتور التشست تيوب والنيزوغاستريك تيوب، معلش قصدي النيزوغاستريك تيوب والميل انتفينيال كاثرايزيشن، هذه ما راح تجي اسوي لها بيرفورم؟
لا، ما انا قلت لك ما حيقول لك انسيرت التشست تيوب. هيقول لك he will ask you questions around the procedure, the instruments, the indications, the complications like that.
بس ممكن تسالني يا دكتور تقول سو ابدومين اكزامينيشن او بريست اكزامينيشن.
اكيد طبعا، هذا الكورس، هذا هو الكورس يا دكتور، هذا هو الكورس. الكورس is history taking a physical examination.
طب الجنرال اكزامينيشن يا دكتور معنا ولا لا؟
معك، كل شيء معك، كل شيء معكم يا شباب.
كل شيء معك فعليا، كل شيء معك.
كل شيء معكم يا شباب.
دكتور سؤال بس.
أوكي.
الحين السيشن هذه الاونلاين نفس حقة اليوم اللي هو ذا فوكس اون ديسفيجيا، هل هذه المطلوبين فيها حنا؟
اسمع، هذه احنا بنراجع، هذه just revision to what we have already mentioned, practical application of your clinical knowledge.
داري، بس قصدي هل هي بتجي في الاوسكي ولا احنا الاوسكي بس اللي فوكست ابدومن جست فوكست زي كذا؟
لا يا شباب، انا يا شباب عشان ما اتكلم عن التفاصيل، انا يا شباب كلمتكم ايش اللي ممكن يجيكم في الاوسكي. اعتقد انه هذا
شباب
الفورمات
حتى الفوكس ممكن يجي يكون فوكس على الهيرنيا مثلا، فوكس على
كل شيء. ايوه كل شيء ممكن يجيكم.
بس
يجي يعطيك سيناريو يقول سوي هيستوري، خذ تيك هيستوري اوف جروين هيرنيا عادي.
بس يعني مش نركز عليها اكثر.
دكتور ممكن بس تقول
يس
ممكن بس تقول لنا على الشيء اللي بيجي اكتف والشيء اللي بيجي باسف، يعني مثلا هذه اللي بتجي اكتف وهذه اللي بتجي باسف.
لا ما استطيع والله يا شباب، ما استطيع. I cannot. لكن بالنسبه لك انت لا متوقع ايش اللي بيصير. اعتقد انه ما فيها مشكله في الموضوع هذا اصلا. يقول لك خذ هيستوري، ولا يقول لك دو فيزيكال اكزامينيشن، ويقول لك اسالك كويشنز.
طيب دكتور، الهيستوري يعني ممكن يكون اي موضوع، مثلا بين ابدومينال بين سويلينج كذا.
شوف يا شباب، ريجاردينج الكونتنت كل شيء ممكن يجي. ما استطيع اتكلم في الكونتنت اوف ذا اكزام. انا اعطيكم
انا ما نتكلم عن الكونتنت، نتكلم على اذا الواحد يبغى يذاكر الاوسكي، كيف يذاكر الاوسكي؟ هل مع الفاينل يعني
نبغى اورينتيشن يا دكتور.
حتى الاورينتيشن انا قلت لكم انت الان يا اما يجي لك بيشن يقول لك دو فيزيكال اكزامينيشن، وهذا ابلاي لكل السيستمز اللي انت اخذتها ومريت عليها، واللي يقول لك خذ هيستوري اجين في نفس التوبكس طبعا. اوكي. او اسالك اسئله اراوند certain procedures and instruments، اكثر من كده ولا اقل.
طيب يا دكتور،
من ناحيه الانسترومنت يا دكتور يعني ما راح يجي
اقرا كل حاجه. ريجاردينج الكونتنت اقرا كل حاجه.
لا ما نتكلم عن الكونتنت، اتكلم ريجاردينج ذا انسترومنت، مثلا سيرجيكال سوتشر ولا كاتيتر ولا تشست انسيرشن. هذه يو ويل نوت بريفورم
اللي اخذتوها في السيميوليشن سيشنز.
اي عارف فاهم عليك يا دكتور، بس يو ويل نوت بريفورم هذه.
انا
يو هاف تو نو اباوت ات.
انا قلتها يا عبد الرحمن، انا اوريدي قلت المعلومه.
بس انا اوضح هذا الشيء للشباب بس خلاص.
اوكي.
احد عنده سؤال يا شباب؟
طيب if you don't have any question or comment please I would like to take I would like to take attendance. Please raise up your hand for attendance.
دكتور
يس
يدي ما ترتفع.
طيب كيف هذا يحلها؟ اسمك مين؟
مرفوع علي مرفوع
معلق عندي
اوكي. تكنيكال ديفيكت.
مرفوع علي.
طيب يا شباب، بورتفوليو
معلق عندي ما تشوف
الاسبوع الماضي والاسبوع اللي احنا فيه هذا تعملوا زي ما عملتوا في
بس دكتور ما شفنا غير حاله واحده.
خلاص اكتبوها ما مشكله.
ما شفنا غير حاله واحده دكتور.
اكتب اللي شفته بس وسبميت يور بورتفوليو بليز قبل نهايه الاسبوع الجاي هذا.
شكرا دكتور.
اوكي السلام عليكم. السلام عليكم.
فهمتوا يا شباب؟ الاوسكي ما هو زي الاوسكي حق البيسك. هذا هو الاوسكي، بيكون عندك تقريبا 10 ستيشنز اساسيين، وواحد هو 21 ستيشن بيصير منها انتظار يعني وكذا. السنه الماضيه جاهم جروين هيرنيا وقال لك سويلنج وكذا، خذ الهيستوري منه فقط. يو ويل نوت بريفور فيزيكال اكزامين. ليش؟ لا يبغاك تاخذ الهيستوري زي هذا فوكس هيستوري. فالفوكس هيستوري از معاك يا حبيبي. من ناحيه الانسترومنت قال لك از معاك يا حبيبي. وجاهم السنه الماضيه اكس راي عن نيموثوركس ما ادري، وجاهم سيرجيكال سوتشر. يعني معاك كل شيء، ليترلي كل شيء، وفيزيكال اكزامينيشن. فالخط اللي كنت بتسويها فيصل الحربي ما اتوقع تقدر تضبط الا لو تبغى تسوي فيصل وسيف وعبد الله الحداد. اذا تبغون تسوون تصوير فيديو للفيزيكال والهيستوري بشكل عام فاتس اوكي يفيد. بس انا قاعد اقول لك الستادينج لازم يصير عنده واحد ترتيب انه يذاكر الفاينل ريتن واوسكي ويسوي خطه متناسقه ومتماشيه.
الرحمن التشيك ليست ايش وضعها؟
ما في تشيك ليست، هذاك ايام
دكتور عبد الرحمن ما نقدر
ما
نتوقع
في
يعني. ممكن نسوي مقطع على الابدومينال اكزامينيشن يجي يقول لك فوكست على مثلا الابندسايتس كذا، كل الابدومينال اكزامينيشن ما استفدنا منه حاجه.
هنا تقول زد على الاكزامينيشن،
مثلا يجي يقول لك سوي لي فوكست اكزامينيشن على الديسفيجيا، يعني هذا حاجه ما اخذناها الا نظري، يعني انت بتالف من عندك باختصار.
انا فاهم عليك فيصل، بس ترى الاشياء اللي تضيفها ترى هي جنرال اكزامينيشن وابدومينال اكزامينيشن، لكن الاشياء اللي تضيفها بسيطه زي ما تضيف ديسفيجيا، اشياء بسيطه بتسوي تشست عشان ما تشوف فيه.
مو بسيطه يا رجال يا اخي، يصير فيها سبيشال تيست.
والله اني انا شفت من امس دقيت عليه 3 مرات وداري اني بيجحفلني، لان انا طال عمرك كلمت الدفعه الماضيه وقالوا لي ان الاوسكي كان زي كذا، يوم قالوا كذا قلت اسلام، قلت اي والله، ودق عليه ما يرد، قلت خلاص بكره بخليه يقول هالكلام قدام الطلاب بعد. فهو المشكله هو ماشي على اوبجكتيف، هو نظام اللي يمشي اوبجكتيف بالضبط. يعني زي السنه الماضيه مثلا، حتى الثيرويد مثلا مين معطيهم السنه الماضيه؟ دكتور طلال. دكتور طلال هو اللي كان في الاوسكي، غرفه الاوسكي حق الثيرويد. في عندك دكتور عماد، دكتور عماد كان ماخذ الريكتال بليدنج، فما تدري ايش بيجيك. وجاهم ريل بيشنت، جاهم مريض صدقي السنه الماضيه، جاهم مريض صدقي قال خذ منه التسبي، وجت
وين كلينيكال؟
لا في المستشفى بيكون. اتوقع السنه دي راح يكون في الكلينيك، ما ندري عاد نشوف. بس اذا
سؤال عبد الرحمن،
هلا حبي،
الهيستوري يعطونهم اوراق ويقولون يلا اكتب ولا شلون، ولا الدكتور يسمعني وانا اساله؟
الهيستوري لا حبيبي، الهيستوري بيكون في معاك دكتور يشوفك تاخذ هيستوري. بالنسبه للاوراق اللي زي مثلا الشيست تيوب ولا الكاثيتر اللي تكون باسف، هذه تكون معك نيرس.
لا يكون بعد يقيمني النيرس
تقييم هي ورقه تعبيها، ورقه ما حد بيقيمك الشفوي، ورقه تعطيك مثلا تيست اكس راي وتعطيك التيست انسيرشن مثلا. حلو، وات از ذا دايجنوستس، تقول نيموثوركس، وش الانديكيشن، وش كذا اسئله على الورقه تكتبها كتابها، بعدين بعد وانت طالع تعطي الورقه النيرس. صلى الله عليه وسلم.
والهيستوري يكون معي دكتور.
الهيستوري بيكون معك دكتور، فيزيكال اكزامينيشن بيكون معك دكتور.
طيب يعطوني ورقه بالهيستوري ولا اخذ شفهي؟
لا تاخذ شفهي طبعا حبيبي.
اي مضبوط، شغله سوالف بس.
شغله سوالف وعلى اعتماد مخك الصراحه، ما ادري شلون
دش يا رجال، سهلات، مش واحد لا يلخبط بس ولا يرتبك.
هو شوف اذا في بلاء من الاختلاف
والله لا جاء طلال والله بتخاف.
وحتى على حسب الدكتور. شوف هو الحلو في الموضوع ان الجميع بيعدي على نفس الستيشنز اللي انت عديت فيها كطالب، مو زي الاوسكي. بس كمان في بعض الستيشنز بتصير دكتور ديبندنت، يعني ما تحس ما ادري ايش بيصير.
سهلات.
اذا جاك ذكر البليدنج سوينا بالديسشارج ابد درجه كامله.
تنجح يخرجونك من الكليه.
يعني اللي قالها الدكتوره تشست تيوب والنيزوغاستريك تيوب والخياطه والكاسترايزيشن، هذه كلها بتجي ما بتجي تطبيق.
ما تجي تطبيق، تجي عليها يعني اسئله.
اخاف يجحفلنا ويقول لي يلا طبق.
لا طيب خلاص هو دافع
ويند كير يا عيال، ويند كير والدريسنج لا تنسوه.
ما راح
في سوتشر، في نيورو فاسكولار اكزامينيشن، دي الاشياء.
طيب هذه السنه الماضيه جاهم نيورو فاسكولار اكزامينيشن عادي مع دكتور سعد الساوي.
يلعب ليس كل شيء.
اي بس السنه اللي راحت ما شرح لهم الظاهر الدكتور شميم.
لا شرحها لهم الدكتور شميم. اقول لك الثيرويد كان شرحها الدكتور شميم واعطاها طلال، ما له دخل، فهي ما هي على الدكتور،
مو على الدكتور.
الدكتور هذا مره مو شرط.
ما اتوقع يعني بتجي من نفس الدكتور اصلا.
بس شلون بيقيمنا على الفيزيكال اكزامينيشن؟ انا الحين قاعد اسوي اكزامينيشن، عنده تشيك ليست ولا يناظر فيه ويحط الدرجه؟
هو عنده تشيك ليست.
وليه ما يعطينا؟
ما يبغى يعطينا قال
يا اخي طيب في مثلا في نورمال براوز غير عن هو اللي يبيه مثلا، مو شرط اغطي الاشياء اللي يبغاها.